Well, thank you, Mattis, for the opportunity to present today on CT myocardial strain, the clinical applications of this technology to patients with valvular heart disease. I'm Joao Cavalcante from Minneapolis Heart Institute. It is a pleasure to share with you some of the work we have been doing using this interesting tool. We talk about strain in application for CT particularly. It's important to take us through this quick journey that CT has been definitely a game changer in the evaluations of patients with severe aortic stenosis now being treated with TAVR. With CT, we can measure the aortic annulus and size, the prosthesis that we're going to be using. We can also decide which axis we're going to use, ideally transfemoral. We can look at the measurement of the coronary ostial height, angles of implantation, but more recently too, the development of myocardial strain with the functional evaluation of these patients has provided us some important insights into the patient's myocardial characterization as well as the myocardial function analysis. When we wanted to obtain CT images and function analysis, and particularly in this TAVR, we wanted to understand that also the number of detectors has improved what we call the z-axis coverage or the scan coverage from top to bottom. The greater the number of detectors, the greater the coverage, and obviously the shorter the scan time and the shorter the breath hold. However, that comes obviously at the expense of a heavier rotation, because the higher the number of detectors, the heaviest it is to rotate this quickly. And this is what this table exemplifies. The greater the number of detectors, the greater the z-axis coverage, but the temporal resolution, which is a proportion of the rotation time divided by 2, has also suffered. And in patients that have valvular heart disease, as important as it is to have this greater coverage, is obviously to have a greater temporal resolution, particularly because these patients have higher heart rates and arrhythmias. Atrial fibrillation is not uncommon. And why am I talking about this? Because temporal resolution is the key word. If we wanted to freeze cardiac motion, avoid blurring, we have to have a very fast shutter. And a temporal resolution is considered the gantry rotation time divided by 2. If you have a dual source system with 2 detectors at 90 degrees, we can then divide this by 4. And therefore, this is an advantage for dual source systems. Now, moving into how we're going to use CT, we acquire this cardiac acquisition throughout the cardiac cycle, what we call retrospective acquisition. We wanted to have contrast on the left side. Then we take this whole data set and we use these double oblique multiplanar reformats to create the cardiac planes. And here in this case, it's showing that the crosshair is going to the mitral valve annular plane centroid cutting through the LV apex. And with this, then we create, in this case here, for example, the 3-chamber. We're cutting through the LV apex and on the short axis, cutting through the aortic valve. And then we now create this plane to cover the entirety of the left ventricle, not cutting the LV apex. And here we have the creation of the 3-chamber. We, for the sake of time, have already created the 3, the 2, and the 4-chamber. And once we take all these 3 long axis views, we will take them for the CT strain analysis. We do place the points in the endocardial border in both the end diastole. We can adjust that, the end diastole being the largest part of the heart. And then at the end systole, has been shown here, adjusting the border so that we do this intersection between the compacted myocardium and the endocardial border. Once we have these 3 planes, we take into the QStrain software that will give us the global endocardial longitudinal strain. In this case here, this value of minus 13.9%. In this patient that has known coronary artery disease. You can see a stent in the RCA, and there was another stent in the circumflex, and multi-vessel infarct. Not only depressed ejection fraction, but also depressed strain. And that's the importance of that. Now, the validation of this software came from 2 groups, with one in Leiden, Dr. Back's group, showing that the strain and EF are very closely correlated, as you would expect, but the strain by CT and strain by echo also had a very good correlation to show that this could be a potentially substitute for strain by CT. In this work that we did back in Pittsburgh, using a different software tool, showing that there was a decent correlation between strain by echo, strain by CT. However, the values by strain by CT were slightly higher or more negative, because these values are not interchangeable. They're modality dependent, particularly because echo tends to foreshorten the LV apex, whereas the apex in CT can be seen, and therefore larger stroke volumes and therefore larger strain values. So the group from Dr. Bax took this CT strain evaluation in patients with severe aortic stenosis that received TAVR and evaluated the prognostic value. And what we can see is that patients that had a higher strain than -14 had worse outcomes compared to patients with preserved strain by CT. And in our cohort in Pittsburgh, 223 patients, using a different software, single source CT scan, this was feasible in almost 3/4 of these patients. We showed that despite having normal ejection fraction when the strain was reduced, and this is the group in red, they had similar all-cause mortality similar all-cause mortality to patients that had impaired EF, but significantly worse if they had preserved EF and preserved GLS. And this was seen not only in univariate, but multivariate analysis. And you can see this nice representation, the value of measuring strain by CT, particularly if the ejection fraction is preserved. We are here now in Minneapolis looking at these multiphasic data sets, pre and post implantation, patients with severe aortic stenosis. And with better detectors with higher temporal resolution, what we can see is that there is a very high feasibility for this to be done consistently. And we would like to see this measurement to be much more automated at our fingertips when we evaluate this patient, so that we can spend our time into the interpretation rather than the acquisition or post-processing of that. Different patient population, patients with transcatheter mitral valve replacement, mitral regurgitation. You can see the annulus dilation, incomplete coaptation in this patient that has also coronary artery disease, and showing that with a specific device that we have a large experience here in Minneapolis called the Tendyne by Abbott. This device has an apical pad that fixates at the apex and connects with the valve via tether. Despite pulling it in, the LV apex, with this apical pad, not all patients had a reduction in the end-diastolic volume. In fact, some patients actually increased their volume or had a very lateral move. And what Dr. Fukui from our lab has been able to show is that the distance from the apex, the true apex of that apical pad, has an important meaning to suggest that the further away, the higher the distance between the true apex to this apical pad, the worse will be the LV remodeling, the worse will be the LV mass, the volume, as well as the strain that we measure, to suggest that it's important to respect the anatomy and the way this ventricle not only contracts but also relaxes. Finalizing this by another power that CT will have to understand why the strain could be impaired is looking at the tissue characterization. By MRI, we can measure this extracellular volume fraction, which has a nice correlation with all-cause mortality and cardiovascular mortality. The higher the extracellular volume, potentially the higher the myocardial fibrosis, or the diffuse fibrosis that we can measure by MRI. But by CT, we can do this measurement by using the pre-contrast as well as the post-contrast CT acquisition. This is a prototype software by Siemens that we're collaborating with the group from Bart's HeartSyn in London for the identification of cardiac amyloidosis, which is not uncommon, about 1 in 6 patients. And the higher the EACVI, and particularly if this EACVI goes above 31%, you have a high suspicion of amyloidosis. And this had a good correlation with the technician DPD scan, which is used in Europe. Here in the United States is the PYP scan. And you can see that there is a nice correlation with the perigeny stage as well as the EACVI. And therefore, that could be important because these patients now can be treated with new therapies. So in summary, global longitudinal strain is a reliable measure of functional CT, which has not only an importance, particularly in patients with preserved ejection fraction with good reproducibility, particularly if we use systems that have a high temporal resolution. Feature tracking is associated with the outcomes, and this comprehensive CT evaluation might become quite important for patients that are being considered for transcatheter therapies. Thank you very much.